Hi, welcome back to IU Radiology Case of the Day. My name is Tim Tsai, and I'm a fourth-year resident at the Indiana University School of Medicine. Today, we've got an interesting abdomen case. I'd like to give a shout out and thanks to Dr. Hill for her help, and of course Dr. Kuntz for organizing the entire Case of the Day initiative. All of the content in this presentation has been fully de-identified to protect patient privacy. Here, we have a 25-year-old patient with a long history of radiation treatment and resections of a recurrent right flank desmoid tumor since the age of 13. Here are the images. We have a contrast-enhanced CT in the axial, coronal, and sagittal planes. Go on and have a look. Alright, now, what are the findings? What is your differential for this case? And what is your diagnosis? Let's go over the images. On the axial image, we see a mass filling the inferior vena cava. The mass contains irregular central calcifications. One might even say that they are slightly ring and arc shaped, but it can be hard to say. The coronal image partially demonstrates the craniocaudal extent of the mass. Scarring of the right flank is incidentally noted, reflective of the patient's history of surgery. The lesion and post-surgical changes are again demonstrated on the sagittal image with partially calcified mass extending into the IVC and right atrium. This is a case of radiation-associated sarcoma, which on histology turned out to be a chondroblastic osteosarcoma. Sarcomas are an unfortunate possible side effect of radiation treatment and occurs in less than 1% of patients. There is a widely variable latency period, with cases reported as soon as 5 and as long as 50 years following treatment. The median appears to be roughly 10 years. Radiation-associated sarcomas most often occur at the edge of the radiation field due to damage to reparative mechanisms without overt cell death. There also appears to be a threshold dose, with treatments less than 10 gray being unlikely to become uncomplicated by sarcoma. The most common histologic subtype of radiation-associated sarcoma is osteosarcoma, and most are poorly differentiated or high-grade. Radiation-associated sarcomas are often indistinguishable from spontaneous de novo sarcomas without being supplied a history of radiation treatment. However, soft tissue extension is a typical feature. For this case, the differential includes recurrent desmoid, primary inferior vena cava leiomyosarcoma, renal cell carcinoma, adrenal cortical carcinoma, non-seminomatous germ cell tumor, and metastasis. Transitional cell carcinoma invasion into the IVC is a possibility, but it's very rare. Bland IVC thrombus could also be considered, although calcified thrombus is also quite rare. A recurrent desmoid tumor would be high on the differential in this case. Desmoids are benign fibroblastic tumors and are the most common abdominal wall neoplasm. While they do not metastasize, they can be recurrent and invasive. Desmoid tumors have no malignant potential on their own, but there are case reports of dedifferentiation into high-grade sarcomas following radiation therapy, such as in this case. They are associated with Gardner syndrome. Desmoid tumors are not typically calcified, but they may be hyperattenuating compared to muscle. They are low signal on MRI and may enhance with contrast. Primary inferior vena cava leiomyosarcoma is the most common primary IVC malignancy. Intrahepatic IVC involvement is associated with a worse prognosis. Renal cell carcinoma is the most common malignancy to extend into the IVC, which would upstage the disease to at least T3b or T3c if there is extension above the diaphragm. This is important to note because cardiopulmonary bypass would be necessary should a surgical excision be elected, and cardiothoracic surgery would likely be involved. RCC is unlikely given the patient age and history. Adrenal cortical carcinoma is a rare malignancy with a bimodal age distribution in the first and the fourth to fifth decades. They may or may not be functional, but nevertheless appear as a heterogeneous mass displacing adjacent organs, often containing calcifications and often invading the IVC. If this patient was a man aged 15 to 34 with a retroperitoneal mass involving the IVC, then testicular cancer would come to mind. Other metastatic disease, specifically to liver, adrenal glands, or kidneys, can also invade the IVC. If you'd like to read specifically about the inferior vena cava, including information regarding anatomic variants and associated neoplasms among other things, I'd recommend this paper. For those of you wanting to brush up on radiation therapy for soft tissue sarcomas, including roles of imaging and complications of therapy, I'd also like to recommend this paper. There's a whole host of complications, such as impaired wound healing, insufficiency fractures, osteonecrosis, fibrosis, cardiovascular complications, radiation pneumonitis, hepatitis, pancreatitis, nephritis, cystitis, and enteritis to consider. So to sum it all up, for radiation-associated sarcomas, their most common histologic subtype is osteosarcoma, and there's often soft tissue extension. There's a widely variable latency period, with a median of 10 years, and there appears to be a threshold below which sarcoma development becomes unlikely to occur. Pitfalls include the difficulty of distinguishing between those associated with radiation and those that are de novo and spontaneous, so a good patient history helps tremendously. The differential also shifts depending on where the radiation-associated sarcoma develops. So as always, thanks for tuning in to the IU Radiology Case of the Day. You can follow along on Twitter at NAKuntz and at Danielle V. Hill, and you can check out our complete collection of Case of the Day materials at the link below. Thanks so much, and have a great day.